Hello and welcome again. We are on lecture number 10 today. This is the last and final lecture in week 2 in our course. Today, I would like to take the liberty to discuss the principles of criteria based progression. The objective of today's lecture are it's to define what are criteria based progression in knee rehabilitation, to understand why criteria are safer and more effective than time based progression. We will also identify key clinical and functional criteria used to advance through rehab phases. We shall also apply evidence based progression benchmarks in range of motion, muscular strength, neuromuscular control, and functional test. So let's begin. In modern rehabilitation, the emphasis is on progression guided by objective milestones rather than rigid timelines. Criteria based progression ensures that each phase advances only when functional goals of previous phase is met. This approach prioritizes quality of movement, stability, and performance over simply time since injury or time since surgery. It allows for individualized rehab pathways, accommodating variations in healing, fitness, and response to training. Applying these principles reduces setbacks in the rehab, enhances patient confidence, and supports a safer return to play or a return to sport or activity. Criteria based progression means we don't advance a patient to the next rehab stage simply because 4 or 6 weeks have passed on the calendar. Instead, we move forward when measurable goals are achieved. Measurable goals like muscle strength, range of motion, or balance are achieved. This makes rehab safer and more individualized. This ensures the patient's tissues are biologically ready before adding more stress on it. Why do we differ from time based progression? Why is time based progression problematic in a rehab program? Well, traditional rehab protocols often say week 2, you need to start jogging, or week 6, you need to start hopping, so on and so forth. But not every patient heals at the same speed. A rigid timeline risks overloading graft or repair tissues. On the other hand, if we progress too slowly just because the calendar says so, stiffness and deconditioning may result. On the other hand, if we progress too slowly just because the calendar says so, stiffness and deconditioning may result. This will cause a setback to our rehab protocol and eventually lengthen the rehab program. That is why we move towards function and criteria based progression. The key principles are simple. The program is individualized, decisions are based on objective measures, and readiness is determined by function, not just by time. At every stage, safety comes first and it is prioritized. The patient must demonstrate control, confidence, and ability before moving on to the next stage. In my experience, it's better to have both criteria based and time based progression. Criteria-based progression helps you progress depending on patient's functional status, while time-based progression prevents you from becoming complacent. So, in subsequent slides, we will allow both these criteria to guide us. But primarily, it will be the criteria based progression that will be guiding our rehab protocol. In the first 6 weeks after surgery, the main goals are restoring passive knee extension, reducing the knee swelling, and regaining basic muscle activation. We don't progress unless 1. The knee can fully extend. 2. The knee can flex comfortably beyond 90 degrees. 3. The swelling is controlled. And 4. The patient can perform a straight leg raise without any lag. These are the foundational milestones. The time-based criteria mentioned on this slide is for reference for all those who have been following time-based rehab progression. In subsequent weeks, we will solely focus on criteria-based progression. From week 6 to 12, we focus on muscle strength, gait, and balance. But before moving ahead, the patient should achieve at least 120 degrees of pain-free flexion. Quadricep and hamstring strength should be about 70% of the opposite leg. And the patient must be able to walk without any assistance. The muscle strength can be measured using either a handheld dynamometer for objective testing, an isokinetic dynamometer, or manual muscle testing by the same person at baseline and subsequently during the rehab program. Balance is also assessed at this stage, with 20 seconds of a single leg stance being a common target in this stage. Let's discuss the late phase criteria now. In the late phase, strength and function must approach near normal when compared to the uninjured limb. ROM should also match the opposite limb. Strength symmetry should be at least 85 to 90% of the uninjured limb. Hop test helps us assess dynamic control with less than 10% difference allowed between the two limbs. Neuromuscular control during drills such as hopping and cutting is closely evaluated before sport-specific training begins. Lastly, we will discuss the return to sport criteria, which is the last phase of any rehabilitation program. Return to sport criteria are stringent. The patient should achieve more than 90% symmetry on isometric strength testing and hop test, which is a functional test. The patient must also demonstrate good movement quality without any valgus collapse or poor landing mechanics. Psychological readiness is equally important. It is measured with tools like the ACL RSI scale or the IKDC scale. Clearance for return to sport is required from the sports med physician. To make objective decisions during our rehab, we use tools like isokinetic testing for muscle strength. This is performed on a machine called the isokinetic dynamometer. Alternatively, a handheld dynamometer can also be used for making objective decisions. Functional tests like hop tests for limb function and validated outcome measures like the IKDC or KOOS questionnaires can also be used. A video or live analysis of a patient helps assess quality of movement. These tools take the guesswork out of the progression decisions and replace them with more objective parameters. This helps us to decide the progression of an athlete or an individual from one phase to another. It is pertinent to mention here the risk involved in premature progression, something that a rehab provider should know, but also the athlete or individual or the patient should also know. Progressing too early can be disastrous. It may lead to graft stretching or graft failure. It may also cause repaired menisci to re-tear and cartilage procedures may break down. Patients who return too soon often develop knee instability, knee pain, loss of confidence, or develop re-injury in the same limb. This highlights why strict adherence to criteria is so very important. So now let's discuss what are the advantages of criteria-based approach. In short, criteria-based progression improves patient outcomes. It lowers re-injury risk, increases successful return to sport, and builds patient trust because they can see their progress measured objectively. Instead of being told to wait until month 9, they feel empowered to earn their progression through their performance. They compete with themselves and their compliance becomes better in each rehab session. In conclusion, the importance of criteria based progression over time based progression cannot be enough stressed upon. The functional benchmarks which guide the criteria based progression makes rehab safe. The objective test the objective testing ensures readiness of the athlete or the individual. Patient safety and long-term outcomes are prioritized in the criteria-based progression. These are some of the references that I have utilized in my presentation today. In subsequent week, we will be seeing in detail about the criteria-based progression in each phase of knee rehab. Thank you for your time. Good day.